Now we'll have 5 minutes for discussion. Hope Dr. Khanna, is it okay?
Yeah, that's okay. I'm at the.
Now I don't know whether speakers are available here. I can see Dr. Arun and Dr. Sandeep.
Let me apologize for this delay, and just to it went out of my hand because we had 3 APVIC sessions, all moderated by international speakers, and they probably went overboard with the time.
But still more than 500 people are watching.
To just on a lighter side, we still have about 350 people hooked up listening to this session, which speaks about the importance and the prestige of the speakers here. All are stalwarts in coronary imaging, and it's already 11:15, and we have 350 people online right now.
Dr. Sanjeev Rai, we covered most of the things. The vast experience in OCT. Do you do OCT in all cases or only specific situations, as you mentioned?
Sir, I think
how often you do your OCTs? Yeah, real practice.
I think the advantage of imaging comes only when you do in the complex scenarios. Doing in simple cases vitiates the advantage. So it's basically the complex case, be it long lesion, diffuse lesions, calcified lesion, bifurcation, left main. These are the subsets where the advantages of imaging. And also in addition, if there is any ambiguity of the lesion, or if you are, find a suboptimal result after stenting as a last resort, you can always use an imaging to clarify. So I don't think it should be used in all the cases. It should be used in only complex cases where you feel that use of imaging can actually make a difference in the outcome.
Since we are doing more and more complex cases, I think these modalities will be very useful. And Dr. Mandi, that will raise a question. And ACS, you said in certain situation. What about in other ACS condition when you use it? Apart from there is a disparity in angio and the clinical scenario, do you use in routine the other cases of ACS? Well, just to optimize the results, is it possible?
Yeah, my choice of OCT is first indication is ACS. In ACS, I definitely see, because ACS you are interested for the intraluminal pathology, endothelial pathology. If you want a superficial, better resolution, OCT is definitely the investigation of choice. If I have a TIMI flow which is less than 2, I don't do OCT, I take IVUS for that. So in case of slow flow, your OCT pictures are very suboptimal, and you don't interpret anything, you unnecessarily give some contrast or something. My choice of OCT is particularly in ACS and particularly in SBG graft. I have an interest for SBG graft. I do almost all SBG graft I image. If I'm doing a PCI, I want to understand those subset much better. And yeah, so I have 4 or 5. I'm observing them 5, 6, 7 cases. I'm observing a similar pattern, so I'm noting those findings. And for me, at least, IVUS and OCT are same. Particularly, as Dr. Sanjeev Rai told, some ambiguous lesion. If there is a filling defect, I want to be very sure what is happening. Then definitely OCT. For calcified lesion, both are okay. IVUS and OCT. For bifurcation, both are okay, unless until I'm very particular about the distal cross or proximal cross or mid cross. Otherwise, rest of the things can be managed by both the modalities.
I think this open question for all. I think there's a change in the use of imaging modalities in ACS. There's a trend towards more and more imaging modalities used to get optimum results and outcome. What about your opinion, Dr. Sanjeev, in these aspects? Whether that will be useful, or there's a trend you can see. We see the research, and if we see the articles, a lot of articles are coming now, all of IVUS and OCT in ACS.
I entirely agree with Arun. I think ACS, more and more cases are being done with OCT, and I'm also doing almost most of the cases with ACS. And remember the cartoon that I showed in one of the slides, where actual culprit lesion may not be the size of severely stenotic lesion in ACS. Second, the non-CAD lesions, like for example, be it SCAD or stuff like that, it cannot be appreciated unless you do an imaging. So I think imaging plays an immense important role in managing ACS. And of course, there are another situation, where I use in ACS the OCT quite frequently. Those are the young patients who come, and I've done a thrombus aspiration. The artery looks clean. I just put in a catheter, and if it is just a plaque erosion, I just leave the artery unstented. So these modalities are quite helpful in making a decision and follow-up of such patients where only erosion has been there, no plaque rupture. We can actually avoid stenting, and hence the long-term effects of the stenting, where you can get even an instant restenosis and stuff like that. So I think it's more and more very useful in ACS situations. And I think as people come aware of its utility, the use will also increase.
Yeah.
I think its previous speaker, Dr. Ron, is not here, but I think he is a strong proponent of routine OCT in bifurcation lesion, and especially provisional stenting, just to detect the floating studs and do kissing strategy if there is a floating studs. What is your viewpoint in this? Anyway, Dr. Ronnie is not there. What's your opinion?
Actually, we don't have a clinical data or a follow-up, randomized follow-up data for this. These are all anecdotal case reports and personal experiences. So obviously, if you look at Dr. Ronnie's case, you are really convinced. For me, if it is a left main bifurcation where circumflex is the major vessel which is getting jailed by some struts, I'll definitely do a kissing balloon, maybe at a very low pressure dilatation, to just displace the struts from the floating struts from the ostium. That is my view. For routine bifurcation, not.
Dr. Sharma, what's your opinion on this? Dr. Sanjeev?
I would absolutely agree. I would absolutely agree with Dr. Montes. I would agree with him, because if there is a large LCX, I would not very comfortable in leaving the struts hanging in between, because we have all seen these kind of cases coming back on follow-up. The provisional left main to LAD being done, and the patient lands up with very bad ISR, especially at the LCX ostium, and I would not be very comfortable. But still, the data is not available to justify routine use of opening the cells towards the side branch.
I think I would agree to a large extent for what Arun and Praful had said. So look, if there is a, let's take a non-left main bifurcation versus left main bifurcation. If it is a non-left bifurcation, the artery size is not a great, and we have a TIMI3 flow, I don't think we need to do an imaging, and we can just leave it like that. But having said that, if it's a large branch and I'm doing a provisional technique, or if it is a left main bifurcation, I'll definitely go for an imaging, and image guided strategy is much important. And when I'm doing an imaging, if I do not have any struts or connectors across the side branch, I just leave it like that if I have a TIMI3 flow. But if I have struts, I'll definitely wire through the distal most struts and then do a kissing balloon dilatation. But on the other hand, if you do not have an imaging modality and somebody is attempting a left main or a large side branch bifurcation in a left main situation, should we do a routine kissing? It's a controversial. But if you look at the EBC main data, I think in the left main, again, this time, quite contrary to the earlier EBC recommendation, they had done routine dilatation, kissing balloon dilatation in all the left main cases, while the penetration of the imaging was hardly 10 to 20%.
That's very interesting. So you are not worried about the ischemic point. You are worried about restenosis. Yeah, because the floating studs may produce restenosis. Because once you get achieved the minimum luminal area, MLA, and you are doing kissing balloon for the floating is mainly because to prevent restenosis and reocclusion.
Yeah.
Correct? The point is okay.
Yeah, but very
You're not
important-
worried about the schema. This is a point you want to make.
Yes.
Absolutely, but we have to be very careful of not injuring by choosing. I mean, we have to choose an appropriate size stent and do that, because you should not injure the ostia. Otherwise, you'll end up in putting another stent.
Okay. We'll take care. The last question to Dr. Sharma. So, if you have two modalities, major modalities, NIVAS and OCT, you dictate the deep calcium. Do you find any difficulty in OCT?
Yeah, absolutely. So for deep calcium, actually, if you ask me, IVAS is the better modality because the penetration of OCT is less. But it is deep calcium does not actually influence the choice of the devices, and and basically does not impact majorly on the stent expansion. So whatever technically, if you ask me, I was definitely better. But for the rest of the other things, including the assessment of calcium, OCT definitely scores, because OCT can actually see the thickness of the calcium, which is
quantification of calcium, and that's better. So, any other points you would like to add?
May I add something to that? See, look, overall, I think use of OCT or even an IVAS in a calcific lesion is quite okay. But as Praful said, we can measure the thickness. And very importantly, when we measure the thickness, we look at the thinnest site when you have a concentric calcium layer. If it is less than 500 microns, it is amenable to balloon dilatation, be it a high pressure, balloon dilatation. Should it be more than that, we cannot break that calcium with a high pressure, either a European balloon or a high pressure balloon or anything. I think then we need to resort to an atherectomy or ablative devices. So I think there's an advantage of using.
Just to add one more point. If you have seen in IVL, whenever you do one IVL in a concentric napkin ring calcification with a wide lumen, you will see that the fractures are most oftenly at the thinnest part of the calcium arc. It is always at the thinnest part of the calcium arc. Hardly you will have any fracture on the thicker person more than 500. Usually the thinnest person gets the crack. So same thing happens for balloon dilatation. I agree totally. If you have a thinner person in the arc, you can try with a scoring balloon or a Wolverine or a cutting balloon where you can get cracks very easily. One area of 500 micron doesn't mean it will not be it cannot be treated by a scoring balloon or a cutting balloon.
Thank you. Now back to Dr. Khanna for the final.
Yeah, I was listening to it. It was a wonderful session on imaging, and we do it routinely in our labs, but whenever I try to sort of replicate this and use this in peripheral vessels, even renals, I get very frustrating results. So, ultimately I tried so many things, balloon occlusion. I mean, size of 4.55, which is a low size in peripherals, it doesn't work. So, but I really believe maybe the technology becomes better and one day we can use this in our vascular work also, especially the carotids and renal. Those are very, very important for prevention of stroke and seeing what's happening in the carotid. So thanks to all of you, and I really apologize for the delay. We had today 13 hours of back-to-back scientific session, and our attendance till now is 7,300, including yesterday and today. We had 19 international faculty presenting today. We had 12 yesterday. We had many society sessions in collaboration with our APVIC. And the special topics today were the TAVI, the full session on TAVI and hot topics in TAVI, and 3 sessions dedicated to TVARs, EVARs, aortic aneurysms, and aortic disease and newer technologies. We had guest lectures from Dr. Rodney White from San Francisco, Dayasagar Rao, Dr. Manutosh Panja, and Dr. Venkatesh Ramaiah from Arizona Heart Institute. And we also had special scenarios session from on atrial fibrillation, critical limb ischemia, and mastering vascular closure devices, and also groin complications. And of course, we had the Ironman, which as usual is a a very sought for competition in worldwide in APVIC. And last we had this wonderful OCT and iOS session, which was wonderful. Actually, I learned a lot today, and I was actually sitting back and learning more today rather than because I'd finished all that moderating, and this I asked Ashokan to moderate, and I was getting wiser and more educated. Thank you all very much. Hopefully in June coming year or July, when we have our APVIC, we may meet physically and have our conference back to physical form. But let's see. On the other side, we hear that COVID cases are rising in Delhi, and maybe if things go fine, we'll have a conference physically. Otherwise, we have to wait another year. Thank you all very much, and we'll start tomorrow again.
Thank you.
Thank you. Good night.
Bye.
Thank you. Good night to all of you.